Hey guys, what I'm going to do here today is run through a basic overview of all the different equipment we should be proficient with in regards to airway management. And I'm going to follow along with a study guide that I have posted. And essentially, this is going to be us going through piece by piece the things you need to know, not just for your career and clinicals and everything, but to kind of help you with this practicum. Okay, so RC150 technically isn't just airway management. So there's some pieces of equipment that are applicable to not necessarily airway, but the course itself. And those are some of the things we'll kind of start with here. So I'm going to just run through this study guide with you. All right, so the first item to address is ABG syringes. Essentially making sure, I know you can identify an ABG syringe, but you need to make sure it's a heparinized syringe. Being able to come up with a good ideal technique for being able to do the different punctures. So knowing the angle of insertion for, radial puncture, with 45 degrees essentially. Brachial, we go a little bit steeper, more like 60. And then ephemeral, which most of you guys won't do, but that's going to be almost a straight up 90-degree type puncture. Pre-analytical errors. So those are the things that can influence our results and give us a false impression of what's going on with the patient. Okay, a lot of different things. The most common thing that comes about with this is really an air bubble in the sample. Okay, when you think about the characteristics of that air bubble, really, really low in CO2, typically high in oxygen, PaO2, or a pressure of oxygen, essentially around 150, 160, something like that. So when you think about the characteristics of your patient, we could have a patient who's hypercarbic and hypoxemic. And what happens is that air bubble in that sample is going to follow diffusion. So it can make more CO2 go out of the blood into that air bubble. And likewise, more oxygen out of that air bubble and into the blood. All right, so that's the most common. There's some other ones. We don't really have to worry about not heparinizing our syringes or anything like that. Over heparinizing or anything. Sometimes with A-line draws, you got to make sure that you're drawing enough waste off and everything like that. But typically, we're talking about the air bubble in the sample and knowing the effects that happen with that procedure, knowing how you're going to orientate yourself to that vessel, knowing once again the degree of puncture, procedure for kind of getting into that vessel, and then post-puncture care, how long to hold pressure for and everything like that. Basic ABG interpretation, this is an essential skill for all your courses. I could very well have an ABG sample out there for you to classify. All right, so knowing your normals and being proficient with that. Pulse oximetry, essentially know some of the limitations. Obviously, we end up having to get good perfusion to that particular place where we're sampling that, and realize some of the different times where that's inaccurate. Okay, somebody that ends up having CO poisoning, somebody with methemoglobinemia, somebody with poor perfusion, and being able to interpret that waveform or that pleth, making sure you get good, steady, rhythmic pulsatile changes in the, and whatever extremity you're kind of assessing that for, to make sure it's an accurate value. We should be trying to link that up with blood gas in our critical patients and stuff. So I don't have the pieces of equipment for that, but now we'll kind of move into things. Okay, so Tidal CO2 measurement. So when you think about the different devices, okay, we have the colorimetric CO2 adapter or detector, essentially. This is going to go on the 15 millimeter adapter, all right, on top of an ET tube. And I see you guys kind of struggle with knowing which way to put it on, and everybody does that. But essentially, you're going to want that sitting on top of the ET tube, so you're looking down and you get the color change. These will typically come as purple in color, all right, and they turn yellow as they're exposed to that carbon dioxide. So typically, we'll see purple as fresh gas is going in, and then yellow as that exhaled CO2 is in that 5 to 6% range. Keep in mind, some of our patients, okay, that since this isn't giving us an exact value, millimeters of mercury, okay, we're detecting the presence in regards to percentage. If you're in the stomach and you can get that big burst of initial acidity, okay, it can give you kind of a yellow change, but it's not really good, and then you're not going to get it for subsequent ones, and usually a lot of other signs knowing you're in the belly, okay? Likewise, if you're in, okay, but you have a patient that is not perfusing, you may have a very, very low Tidal CO2 because you don't have perfusion in your lungs, okay? So keep that in mind. This is not giving us a value, okay, just a color. It can be limited. Make sure, once again, as you're confirming presence of an ET tube in the trachea, all right, typically combining that with breath sounds and making sure we get good color change for 6 breaths. But realize that if you have poor perfusion or something like that, you could be in the proper place and not actually get color change. All right. And then once again, I said that hooks up like that. Your ambu bag is going to hook straight up on the side right there. Okay. We don't need to get in a hurry ripping this thing off right away. There's no reason why you can't leave that on as you're manually ventilating until we secure the patient's airway. Okay. But the limitation on these is they're typically limited to just placement of airways. All right. The other thing we have, and this is the side stream, so there's mainstream too. But this is a continuous waveform capnography. So it's in Tidal CO2 monitoring, but it gives us a value and it gives us a waveform. Okay, so this can also be used for confirming airway placement, and it's actually better than the colorimetric because it gives us a value. And the picture is worth 1,000 words. We can tell a whole lot about kind of what's going on with that patient. You could hook this up in line with your ambu bag as well. Okay, so you can see it goes on right like this here. And this end can end up hooking up on the endotracheal tube. All right. Likewise, as I told you, I like using my inline suction. If you had that hooked up, you can likewise have that straight in over to here, so you get it kind of away from the ET tube. And if you get a bunch of stuff spraying up and out, you can kind of worry about it so much. And we'll go over the inline suction a little bit more here in a second. If you look here really close, there's like a little bit of a braiding right there. Okay, that's like a filter line. So it's supposed to be a little bit more impervious to moisture and stuff like that from our intubated patients and everything. So if you come across some at the hospital and you see some with this that are yellow, you'll also see some that are orange and don't have that. These are usually a lot better for our patients when we're worried about moisture and everything like that. So the benefit of this is not just can we use it for placement of ET tubes and artificial airways and such, we can use this for monitoring and trending, okay? We can also use this for cardiac arrest. So essentially we know that for us to have CO2 exhaled, we have to have perfusion to our lungs, right? So we can use this to gauge the effectiveness of CPR where we couldn't do that with a colorimetric adapter. And essentially what we find is if that CO2 is less than 10 millimeters of mercury during CPR, all right, that's you're not really doing good chest compressions. And that could be for a bunch of different reasons. Could also be some stuff going on in the body, okay? But less than 10 is not really a good sign. Likewise, we can also see as that patient's CO2 shoots back up really, really high that we can assume that maybe that patient had a return of spontaneous circulation or ROSC, okay? So these are very, very useful, not just for confirming tubes, but you have other instances where they can be valuable. Keep in mind that capnography is based upon perfusion, okay? So if you have a patient that you think you're in, but you think that maybe they don't have very good cardiac output or they're pulseless, keep in mind that that is a limitation with this and don't overly rely on that, okay? So that needs to always be in your back burner. If you think everything's fine, you got bilateral breath sounds, but no color change, maybe check a pulse on that patient, okay? So that's in Tidal CO2. Keep in mind, if we are using the continuous waveform, it does have limitations due to dead space, okay? So just because you're in Tidal CO2, it's picking up doesn't necessarily mean it's an accurate value. And it is limited, especially in patients that we take care of because they have bad lungs most of the time, okay? And some of them have a high degree of dead space. All right, so Mannion Resuscitators. Everybody thinks they can use a bag, all right? Everybody can, but it's essential to kind of know some of the parts. This is a self-inflating resuscitator for an adult, okay? Gives a very, very large volume. You don't need to completely squeeze that when you're breathing for your patient. Keep in mind we're going to get chest rise. You have your oxygen tubing hookup. This will hook up with or without a Christmas tree, okay, due to this round shape there. We want to run this in 15 liters a minute, all right? If you have something like this, and these come in a bunch of different variations, sometimes it's a big clear bag, sometimes it's just a piece of corrugated tubing that goes around, but that's our reservoir, all right? It allows us to give 100% oxygen. You don't need to run this at flush, okay, in order to give 100%. And flush on this thing makes it where you can't hear and it'll drive you crazy, okay? 15 liters a minute, as long as you're hooked up to a reservoir and oxygen and everything like that, you're all good, okay? Back here, there's one-way valves that allow oxygen to only go into the bag, okay? So essentially, we're pulling stuff in. As we squeeze that and it's inflating, it's going to pull stuff from the reservoir again, okay? Over on this side, this is where people really struggle, and every ambu bag's a little bit different, and everybody's been through this before where you're struggling, okay? But all of them are going to have a spot that is essentially going to take that 15 millimeter outer diameter of any of our artificial airway stuff, okay? So let me grab my ET tube here again. You can see this is going to hook right on like that. Likewise, in regards to airway troubleshooting, remember all of our stuff is universal measurements, okay? Corrugated tubing, We got the 22 millimeter inner diameter, 22 millimeter outer. The biggest thing I see people mess up on is trying to figure out where to hook this thing. Okay, so you should be taking a look at your ambu bags when you're at a facility, and you can always see there's a one-way valve right there, a little diaphragm that closes off to prevent that patient from exhaling into the bag. Okay, and likewise it opens up whenever we're pushing breath into the lungs and give them that fresh gas here. Okay, so you can maybe see the little opening right there. That's a little one-way valve. Okay, hardest thing in the world is breathing for a spontaneously breathing patient, or breathing along with them to help. Okay, and if we get out of sync with them, it's very uncomfortable for them. I'll watch their chest rise, but you can see as they're starting to breathe, if you watch that valve, you'll see it start to open. So a lot of times I'll just watch that valve in their chest, and as it starts to open, I'll go ahead and I'll breathe along with them. Okay, the other thing people mess up with, you'll see this little opening on the back here, and they start trying to stick stuff in. It's just shaped that way because of the piece that that one-way valve attaches to on the inside of this. Nothing hooks up on the back side. Okay. The other thing that's very, very confusing for a lot of people is, where do I put a PEEP valve? Okay, so once again, when you have a one-way valve that allows that patient to exhale into the ambient atmosphere, every ambu bag is a little bit different, but essentially you'll see some sort of an opening. And a lot of times it's shrouded. It's got something, otherwise, you know, if we had a big juicy coat or somebody with hemoptysis or pulmonary edema, you'd be bagging that stuff and spray out. So you can see a lot of them come with this little cap. You don't need that cap to operate, okay, but you can see that's essentially where all the gas is coming out of. If you have a PEEP valve, all right, PEEP valve is just a little spring-loaded diaphragm. It's got little units of measurement on there, and we can dial it in to whatever level of PEEP we want. And then this is a hook right on like that there, okay? That way when we give a breath in, we're giving fresh gas. When they exhale, it tries and capture a little bit of that, air, leave that air in the lungs to maintain that pressure. We don't have to use this on everybody, but if you have somebody who's oxygenating poorly, you could use it. You got to know why they're oxygenating poorly or have an idea, okay? Because if it's due to hypotension or something, you can make matters worse. Most notably, we'll use these if we have a patient that's on an increased level of PEEP on the ventilator, so 8, 10, 12, 14 and above, stuff like that. That way, if something bad happens, we can switch them over and we can maintain that level of PEEP they're getting on the ventilator. We can maintain that during manual ventilation, so we don't get that lung de-recruitment and worsening oxygenation. Okay, so you got to realize every place is going to have different resuscitators, so get kind of familiar with the ones you have, okay, and make sure you know how to use those properly. Some of these have a cap. We leave all of our ambu bags on the wall for the patient and stuff like that, hooked up to a flow meter in case something happens. This just kind of keeps it sealed up a little bit. All right, then likewise your mask goes on right like that there. So manually ventilating a patient. So if somebody's actively breathing, we don't just give them a breath every 5 to 6 seconds. We're breathing along with them. We're supporting them. And that's where you got to get in sync with them, okay? As far as the rates go, if we have somebody who codes and you don't have an artificial airway, that's just BLS. All right, 30 compressions, 2 breaths with a Mannion Resuscitator and a mask, and then kind of keep repeating. Once we get an airway in a patient, things kind of change a little bit. Okay, so if we have somebody in a cardiac arrest, once we get that artificial airway, all right, we don't have to pause during chest compressions or we don't have to pause chest compressions to give our breaths. Due to the fact that these patients' problem is that they don't have their heartbeat, they have poor cardiac output. It doesn't make the patient do any better by squeezing that bag faster. And actually, we have a little bit of a slower rate for somebody who's in cardiac arrest with an ET tube. All right, essentially, we're trying to give those patients a breath every 6 to 8 seconds, which equates to about 8 to 10 breaths a minute if they're pulseless and have an artificial airway. Okay, if that patient were to start having poor oxygenation, you see people bag them faster, bag them faster. Well, their problem is that they don't have a heart rate. Okay, they have poor cardiac output. So every time we squeeze a breath into that patient's lungs, we can decrease venous return and we can negatively affect that cardiac output. If we have a patient that we didn't know anything about and that heart rate comes back, we have that airway in, all right, we should do just rescue breathing. 1 every 5 to 6 seconds, which equates to about 10 to 12 breaths a minute. If you gave everybody 10, that'd cover you for both your bases and stuff. That being said, that's if we don't know anything about those patients. If something happens and we're taking a patient off the ventilator and they're on a rate of 30, we know more about them. We will want to match that respiratory rate as long as they have a pulse and everything like that. Sometimes if somebody comes back post-cardiac arrest and we know they're super acidotic or something, the more we know, we can stray away from those BLS standards in regards to the people with a pulse. But keep in mind, don't be squeezing that bag like crazy. If you have a patient in cardiac arrest, you're actually not going to help them, probably going to make things a little bit worse. Okay. So that's kind of going through all the different parts of the Mannion Resuscitator. All right, one thing that can really help us in regards to ventilating somebody without an ET tube or an advanced airway is an oral airway. Okay, so OPA, oral pharyngeal airway, for those patients that are unconscious, okay, and you're having trouble getting chest rise, and we should just be squeezing that bag until we get chest rise, nice slow breaths, okay, especially if you don't have an ET tube, until you get chest rise. Give that breath over about 1 second. Sometimes if you're squeezing and it's really tough to push that air in, or you're not getting chest rise, we can assume you got soft tissue obstruction. So your tongue is back on the back of your oropharynx and occluding your airway. An oral pharyngeal airway is something that can kind of help alleviate that if you size it properly. Okay, so we want this typically from the corner of the mouth to the angle of the jaw here. If it's too big, it's not really gonna, I mean, sometimes it can end up just getting more in the way than anything and not keep that tongue all the way pulled forward or anything like that. Most of the time, bigger is better than going too small. If it's too small, we're not going to get back behind the tongue, and you're not really going to open up that patient's airway. Okay, these are only for unconscious patients. If you put one in somebody and they start to come to, you got to rip it out right away. All right, and then you'll see different variations. So there's ones with one center channel, and there's one with two channels running along the outside. Essentially, a Guidel is one that has one big inner opening, and that allows us to push air through. You could also push a suction catheter through if you wanted to. And then the Berman has two side channels on there. Not that you need to know that or anything. So if you see different variances, that's all this is. So this can help us when we're not able to get chest rise with manual ventilation, those patients without an artificial airway. And these come in a package, obviously. I always usually have one in my pocket at the hospital, just because it's one of those things when something bad happens, it's better to have one instead of having to scurry around and get one. Okay, so knowing how to size this, knowing why we use this, how it works, and recognizing that if you put it in somebody and they wake up, you're probably going to vomit and get into a whole other issue. Okay, so then we have the nasopharyngeal airway, the nasal trumpet, the MPA. These can also serve kind of a similar purpose. Okay, they can keep the tongue from occluding and falling against the back of the airway if you size it properly. Although the most common or most frequent indication for seeing a nasal trumpet or these nasal airways is probably due to frequent nasotracheal suction. All right, so once again, it's important to measure these properly, especially if you're trying to use it as an airway adjunct to keep the airway open. You want to go from the tip of the nose right to the tragus of your ear, your earlobe here, even. And I usually follow that same kind of curvature. All right. If it's too big, it could go down past the base of the tongue too far and stimulate some gag reflexes and stuff like that. If it's too short, I should say, you're going to be fine for nasotracheal suction. It's going to get it where you're not irritating the nares every time you're going up and through there and everything like that. But the problem is going to be if they go to lose consciousness and their tongue includes their airway, if it's not long enough, you're not going to get that benefit. So I try and put a long enough one in, even if I'm doing it for NT suction, where I get that ability. But if you're just using it for frequent NT suction, the length isn't so important. It's what size diameter you can get in to go comfortably. These are okay for a conscious patient. Okay, it shouldn't stimulate the gag reflexes and stuff as bad. It's not going to be pleasant when you put it in. Although it shouldn't bother them, and it shouldn't bother them as much as going up through their nare with a regular suction catheter every single time. And we already talked about methods for insertion on this, what to do if you're meeting resistance and everything like that. Okay, so laryngoscope blades and handles. Okay, so laryngoscopes allow us to essentially view the larynx and the vocal cords, right? So these come in a bunch of different variants. You have the disposable ones that are coming a little bit more common, and then you got some of the stainless steel ones, metal ones that are reusable, okay, and you have to change batteries out and stuff like that. So we need a handle, which is essentially our power and our light source, okay? It's going to power up our light source, I should say, and then there's a bulb on the blade itself, okay? So one is no good without the other, and when you think about it, it's important to know how to identify these different blades and how they work. So the curved blade is a Macintosh, all right? If you read on the back of this, it usually say, you know, Mac 3. Sometimes they're labeled on the sides here instead. A Mac 3 and a Mac 4 are about appropriate for an adult size. All right, the bigger the number, the larger the blade. On this handle here, you can see that metal bar. All the handles are the same. You're going to take those grooves. That bar is always going to be kind of facing towards the tip of that curve there. All right, you're going to push until it clicks, lock it in place, and then check and make sure that it lights up. Okay, that being said, I check it, I get it all ready, and then I unfold it like that and leave it locked on, but I'm not using up my battery source or anything. And then that way, when the doctor's ready to intubate, click it in, and you're good to go. All right. This is something you have to ask the physician who's intubating. You should also know that this blade is responsible for how it's responsible for opening up the airway or lifting the epiglottis. This one's going to be indirectly. So you're going to kind of sweep that tongue, kind of stay to the middle, to the right side, and keep that tongue kind of in place. Advance until you get into the valleculae. All right, we're lifting with a firm, direction. Just moving that blade in one direction. You're not rocking back or anything. And then you're going to lift that epiglottis indirectly, and you'll hopefully see the vocal cords. Okay. The other variant is the Miller, the straight blade. Okay. Usually a Miller 2, sometimes a Miller 3, but Miller 2 is a pretty standard for adults. You'll see like Miller 0s and double zeros and stuff like that in the neopeds world and everything like that. Same deal. You can see it's labeled Miller 2. All right. Same deal. This one, you're going to do the same procedure, except as you see that vallecula, you're going to go, or as you're going down the base of the tongue, you'll see the epiglottis, you know where the vallecula is, but then this one actually directly lifts the epiglottis, okay? And you're going to go ahead and lift her on up, and you hopefully see those cords advance that ET tube. All right, the disposable ones get trashed after intubation. The reusable, we usually take, I'll put it into a glove. We wipe down the handle, and then the blades usually get Sidexed or some sort of disinfection and everything like that, okay? And that's usually our responsibility, and then to make sure it gets back into an airway box. Okay. Let me see, I got a lot of equipment here. Let me drink a little coffee. A Stylet, okay? A Stylet, it's almost like a malleable coat hanger type thing. This is for really easing the insertion of an endotracheal tube, all right, during oral tracheal intubation. We don't use these for nasotracheal intubation, okay? But essentially, a Stylet is going to give us a little bit of rigidity to the ET tube instead of trying to push this through and the thing kind of bending over on us or something like that. By pushing this through, and it's going to go in through a 15-millimeter adapter. You're going to push it, make sure it's not sticking out the end, but it needs to be fairly close. And then remember, our cords, her patient's larynx is anterior on their chest, right? The hardest part is going to be getting up and into there instead of going back and down and getting in the esophagus. So you always want to put some sort of a bend on there, all right? Whether you do like a hockey stick or a J, if you give a ET tube straight, not that you couldn't get it in, but it's making matters a little bit worse. We want to try and bump that thing up and through into the vocal cords and penetrate that anterior larynx and everything like that. So once that's in, once we think we're in the trachea, once again, that physician is going to grab the tube or somebody is, we need to pull that Stylet out because you can't do anything with that Stylet in. We can't hook it up. Be careful that you do not forget the Stylet on a lot of your guys' intubation checkoffs. I noticed you would check that ET tube and do all that stuff, but you would sometimes forget to put that Stylet in until kind of late. So part of our routine, as you're checking this thing, everything's good, putting lube on, get a bend on there, put it in the package, and that way it's all ready to go. All right. So parts of the ET tube, all right, while we're on it here and we're moving past the Stylet, first off, the 15-millimeter adapter. So this is, no matter what your tube size, this outer part is going to be 15-millimeter outer diameter. And that allows us to hook to all of our ventilators, suction catheter, or inline suction, ambu bags, all of our essential equipment, okay? The only thing that changes as the tube size changes is the size of a hub that kind of sticks down and into the tube to keep things put. Okay, so you can see this little piece changes in size, but this is always 15 millimeters, even if we have a tiny little kid's tube. That being said, these things are notorious for getting stuck in our equipment coming off. So when I do an intubation, when I'm checking my ET tube, general rule of thumb, I'll push that thing down to make sure it stays put. We'll address what to do if you have a hub that keeps popping out on you at a later time. I'll do another video on kind of airway troubleshooting and everything. So 15-millimeter adapter, okay? Other things we have here, so it's important to know that we have our units of measurement here. So there's little lines or little arrows that denote, how many centimeters of depth we are. So that's really, really important when we're confirming tube placement. are important to line up as we're maybe doing a ET tube exchange or suctioning, rescue cath, some of these different things. All right, so we got our units of measurement. It's important to know that we describe all of our ET tubes by the inner diameter, not the outer diameter. So ID 7.5, so being able to kind of read these. All right, if you're opening a package, it's going to say what size it is, but sometimes it's important to be able to look at a tube and kind of confirm if EMS is bringing it in, or you're taking on a patient, or making sure somebody charted something right. We have our cuff here. Okay, you can see I got this partially inflated. We talked about methods for inflation. Okay, you can see kind of my beveled end here, and then I got the Murphy's eye. So the Murphy eye is responsible for if we get that distal kind of occlusion of that airway, we have a kind of ability to still pass air through that. All right. We have a radio opaque line, so that allows us to see this on a chest x-ray. You know, we're shooting for that 2 to 4 centimeters mark above the carina. I can kind of know what happens if you have that patient kind of, you know, extending their neck versus flexing their neck, and what it does in relation to that tube tip. Okay, typical adult male, we're talking 21 to 23 centimeters at the teeth. Adult female, maybe 19 to 21, and that's going to be dependent upon their height and their anatomy and everything like that. All right. Keep in mind, if you have somebody that is in a C-collar and their neck is kind of extended and pulled up like that, it's going to pull that anchoring point of their teeth further away from their carina, and it's going to have to be a little bit deeper. Okay, so don't question the doctor if they're in a C-collar and you end up having to push that thing in a little bit deeper. And intubating somebody with a C-collar is a whole other issue. Sometimes we end up having to take that C-collar off and do manual stabilization and a bunch of other stuff that you kind of get used to. Couple other things here. So we got our pilot balloon, and it's essential. I'm going to kind of know these different things I'm talking about because I'm going to do an airway troubleshooting video here in a bit. Pilot balloons gives us a little but a little spring-loaded valve here that'll take on a syringe drawn back and filled with air. All right, it allows us to facilitate air through that pilot balloon into the pilot line. So the pilot line is the part coming from the balloon going down to the cuff. Okay, and we're going to talk about all this on troubleshooting video here a little bit later on here. So pilot balloon, pilot line, cuff. Some of our ET tubes have this other little adapter. This is called a subglottic suction or a high-low evac endotracheal tube. This little cap comes off, and this yellow piece, all right, allows us to pull in oral secretions that sit on top of that cuff. It allows us to pull that out through the continuous use of low-level suction. So you'd hook up suction tubing off of a canister right onto this, typically negative 20 millimeters of mercury. Okay, and that's constantly kind of pulling stuff up and out of there. And then every 4 hours, or when you're going in to see your patient, we should take a 10 cc syringe, take that off, take the suction tubing off, do an air bolus only, never add liquid down there. Okay, and that just makes sure that nothing's getting gunked up and this line is staying unobstructed. Keep in mind that anybody that is going to be on a ventilator for a prolonged period of time, or you think they are, we should try and use a high-low suction or subglottic suction ET tube, because it's going to decrease the risk for ventilator-associated pneumonia. All right, so by decreasing the oral secretions pulling on top of that cuff, we can hopefully decrease their incidence of VAP. That being said, sometimes things go wrong with these, and you're having to try and figure out what's going on. You hear weird noises coming from your patient's airway. Sometimes this can kind of almost latch on a tissue since there's just one port on here. Okay, so if you're trying to figure out, is that noise a cuff leak? Why do I hear this upper airway noise? Sometimes I will disconnect this as I'm troubleshooting that patient's airway. Okay, so subglottic suction. Talked about a lot of different parts here and everything like that. And you can see I have a standard ET tube over here. We don't have that other adapter. You just got all the other same things we talked about, but you got a pilot balloon and a pilot line, no subglottic suction itself. Okay. So let's see, adult, what else do we have here? So, so if you're going to try and put in a endotracheal tube through the nose rather than the mouth, you got a couple of options. We can do that with a bronchoscope, and I'll kind of show you that in lab. All right. You could do that blind, so go up through the nose, just like NT suction, and hope you can get down into the trachea. All right. If you were going to do the nasotracheal intubation and you could still open the mouth and everything, but you're just going through the nares for another purpose, the hard part, since we don't use that stylet, is guiding that through the cords. So you could use a pair of McGill forceps, okay, and that allows us, as that tube gets to the back of the nasopharynx and dropping down in the oropharynx, and we're trying to line up and get that to go through the vocal cords, this gives us the ability to grab on you still got to use a laryngoscope, and we can allow this to kind of help us push that tube in through the cords and everything like that. I'll be honest, most of the nasotracheal intubations I've done end up being either blind or through bronchoscopy. I very seldomly use the McGill forceps, but you'll find in your Airway cards, and it's essential that you know what these are and what they're used for and how to use them and everything like that. So proper ET tube sizes, I think I skipped through that. 7.5 to 8.5 for an adult male. We try and shoot for an 8. Likewise, a 7 to 8 for adult female. We'd like a 7.5 from them at least. The problem is if you get too small of an ET tube, it takes too much pressure to make a seal with that cuff, and we worry about mucosal ischemia and some of the problems associated with that. Likewise, the smaller that airway, the more resistance, the harder it's going to be to ventilate through. The smaller suction catheters we have to use, and that kind of becomes all a big problem, especially depending on the patient you're dealing with and everything like that. So then we have a dual lumen or endobronchial tube. Okay, so when you look at this, and we'll talk more about this in the strategy for in our advanced vent class, but you essentially have 2 tubes fused into one. You have 2 15-millimeter adapters, and you got 2 balloons here. Where's my syringe? I'll inflate this thing. Yeah. So this would be if you have patients with something going wrong, terrible different characteristics on one lung versus the other, big air leak, something serious going on one side. All right. You could use this, and you could provide different ventilation strategies for both. I only got 1 pilot balloon here, but usually these would have 2. Okay, one of mine got ripped off. I got a leak because of it here. This one's kind of torn as well. But you can see this tube would go ahead. You have an opening here and then an opening here. And we can actually get that thing endobronchial. We can inflate both balloons, and it allows us to go ahead and direct that air out of one tip into one lung. And then we have this balloon sealing everything up and above. This balloon would keep air from going down into the bronchial intubation, and that other air would ventilate the other lung here. Okay, so sometimes they'll have a single pilot balloon. I have seen a couple of doubles and everything like that, but mine are torn. You can see one here, one here. All right. And this required 2 ventilators here, 2 suction catheters, and it tells you bronchial. So typically, like a main stem, and then which one is actually directing air out of that side port of your trachea and everything like that. So endobronchial tubes, we'll talk more about that in our ventilation class. Okay, that's about it with the ET tubes. Trachs. So being able to ID trachs, and our common ones, we got the Bavonas and we have the Shileys. Okay, so we already talked about identifying a trach. You can tell a lot by looking at it, all right, because we're a little more familiar with trachs than other people. The flange, this big piece that allows us to anchor, it's going to tell us where all our important stuff. A Shiley tells you the diameter of that airway and everything like that. Sometimes it'll tell you the length as well when we have very length trachs. All right, so being able to tell a Shiley versus a Bavona. All right, so the Bavona is more siliconized. Okay, it's got a sterile water cuff. If you got the little clear pilot balloon here, they do make Bavona air cuffs, which would be blue like the sky. You fill those with air, and they tell you air cuff. And then you have foam cuffs, which you shouldn't see a lot, but it's got a red pilot balloon, and we don't fill that with anything. You use this atmospheric air. The Bavona, since it's siliconized, all right, less likely for the biofilm and secretion and adhesion and plug-in and stuff like that. But the problem is it doesn't have an inner cannula. If anything bad does happen, all right, we'd have to swap that trach out and end up replacing it with another. The Shileys typically all have the removable inner cannula. Most of the time they're the clip lock, so it clicks in with these 2 little wings right here. But you do have some other Shileys out there, like this is an extra length, so the proximal extra length, so it sticks out a little bit more out of their neck and everything like that, versus a distal would be a longer one. These particular ones do have like a twist lock inner cannula. Okay, so you push it in, and then this piece twists and locks in here. All right. So you won't see fenestrated trachs a lot or anything like that anymore, but fenestrations would just be little holes on the top part of this outer cannula. And the only way those fenestrations would work would be if you pull that inner cannula out and then plug that tip, whether it's a speaking valve or a cap or something, and then it allows air to go up through those fenestrations and up through the vocal cords for speech. All right, there's some problems with fenestrations, and certain patients, especially depending on where it's at, it could end up causing problems as it's rubbing on tissue and everything. So you don't see fenestrations used a whole lot anymore. Honestly, if you're trying to get a patient to speak and use their upper airway, again, can't really go any better than the portex of the Bavona tight to shaft, because when you deflate that cuff, it looks like a cuffless airway here. Oh, what else do we need to talk about? Okay, so obturators. So obturators are specific to the trach. It's not like we go and grab a box of obturators. It's going to come with one, okay? But essentially that allows us to, in the case of Bavona, not only have like a snowplow effect, but it adds a little bit of rigidity. But instead of trying to put this big old giant tube through, it gives us a little tip so we can start through that stoma and then slide that thing kind of in place. Then we pull that out and get everything all hooked up. All right, so an obturator eases the insertion of an airway, but we got to pull it out as soon as we kind of get it into place. What else do we have to do? We talked about changing trachs, indications for tracheostomy tube, but it allows the easier weaning. So those patients are difficult to wean. Gives us a lot of options in regards to popping them off the ventilator for short periods and then putting them back on rather than extubation. You know, we could do emergent tracheostomy tubes, so that's acute airway obstruction. You can't get them intubated, you know, trauma, stuff like that. A lot of different things that could cause that acute indication of tracheostomy tube. A lot of times if somebody needs prolonged positive pressure ventilation, we can go ahead and put a trach in them as well. Talking about trach care, you know, all the supplies with that. Let's talk about some of the things that go on the trachs, and I'll show you a couple other different variations of the Bavonas here. Okay, so some of the different things we can hook onto the end of a tracheostomy tube. First thing is a speaking valve. So a speaking valve, this is a Stylet speaking valve. You can use it with any tracheostomy tube, but it's not a true passing mirror. A true passing mirror is typically that purple color, but they all work the same. Okay, it's a one-way valve that allows that patient to breathe in through their tracheostomy tube, but when they exhale, this little flap closes and air goes up and through the vocal cords, hopefully. All right, we need to make sure the cuff is down, otherwise your patient will die. All right, and it's still important, since they're breathing through the tracheostomy tube, that even if they're doing well, at least popping that speaking valve off, you know, and routinely sticking a suction catheter through just to make sure it's patent. I'm not saying deep suction, but at least going to the end of that tube to make sure you're keeping that thing cleared. Otherwise, secretions get back behind here, and it can cause problems if nobody's checking it. Some of these speaking valves, especially the Stylets, love this little clip on the side. You could hook humidified oxygen tubing up to this just to add a little something. So you could also use a speaking valve and a trach collar. Some people say you can't because you get water drops on there, but it shouldn't be a problem as long as they're monitored and everything. But if you have a patient getting up and walking around, doing a little ambulation, you can hook them up to a little low-level, low-flow oxygen through this, and it hooks it straight into the tracheostomy tube. Okay, so a speaking valve is a one-way valve. Breathe in through the trach, up through the cords. Then you got a cap. All right, so let me just kind of show you how these things go on here. So these are obviously just going to go on to the end of the 15mm adapter of our airway. All right, a cap here. This is actually a Bavona cap because it's just a red cap. It goes right on there. If you cap somebody's airway, now all their breathing is actually occurring through their upper airway. Our trach's there if we need it, but they're not actually using it. Same deal. I still pop my caps off and try and go down and make sure my patient's airway is not, you know, getting gunked up and it's staying nice and patent in case we do need it. Because a lot of times these patients are just going to be capped for maybe a couple times during the day, and building up to capping is tolerated and everything like that. I like these caps. Make sure you push them on real good and strong. Otherwise, I can cough that thing off and up and out of there. Okay. These come with a Bavona. Some departments have bags of these as well. All right. Then we have this. This is also a cap, but this is for a Stylet. So with the thing about the Stylet caps, I don't like, you got to take the intercanal out, and then you can clip this on. Now you're capped. Well, I don't like these because you end up getting the inside of your trach all gunked up and everything like that. We don't pull this out and clean it. So a lot of times, what I like to do, if I have a department where I have these caps in, I'll get a Bavona cap and put it on like that there. Okay. Where the cap like this is very, very beneficial is with a Stylet. If you had a fenestrated trach and you needed that intercanal to be out, these do allow you to kind of do that. There's a couple of other weird Stylets out there that are the twist lock cap. So it's got an intercanal with a red piece on there, and you push it and lock it in place, and kind of the same deal. It caps it. I like that one because you're at least not gunking up your trach itself. Okay, so caps. Caps allow the patient to breathe through their upper airway. If anything bad happens, obviously we take that cap off and get them breathing back through their trach again. But a lot of times the progression of speaking valve, cap, and then trying to decide, are we trying to decannulate these patients and take the trach out or leave it in permanently? Okay. Another thing you can do, if we've got a patient that you don't want to be tied up to stuff, trach collar and everything, you want to get up and ambulate, whether you need oxygen or not. This is called a thermovent. I call it a barrel HME. It's essentially a little HME that hooks onto the end of a tracheostomy tube, just like this. Same process of ventilation, HME. They exhale moisture and warmth, and then as they draw on their next breath, it kind of pulls that into this wick fiber. Okay, this particular one is a fancy one I haven't seen. It's got a little port for going down and suctioning them out and everything. I'd probably just take it off. It's also got a little port for oxygen down here at the bottom. Some of the other thermovents, they'll have like a little green clip that goes on with a little piece of oxygen tubing and stuff. But it's a barrel HME. It provides humidification if they're up and ambulating or they don't want to wear the trach collar or something like that. Not as good as heated humidification, but still, 70% relative humidity, give or take, something like that. You need to make sure these don't get gunked up and cause problems for that patient. Okay, one of the other things I'm a big believer of, and you always need to make sure you put one of these on for your patients with a tracheostomy tube when you get on the ventilator, is the Omniflex. So the Omniflex are a little accordion-looking adapter. Instead of a ventilator circuit pulling on my trach and torquing it, this adapter goes on right like this. And then whatever I hook up to, whether a lot of times it's going to be suction, instead of it torquing and pulling on my airway, it's got something that's got a little bit of a give to it, rather than me hooking up a heavy ventilator circuit being like this, and then it's pulling on my trach and irritate my patient's neck. So the Omniflex is really, really good for your patients if you're hooking up and manually ventilating them, or you're hooking them to a ventilator circuit or anything like that. And a lot of times you'll see it something like this. Now the one problem it gives you is when you go to suction, the suction catheter can end up rubbing on those ribs and you can get hung up. So one thing I do whenever I go to suction, if you pull that accordion in, all right, and kind of claps that accordion, it allows it for you to pass that suction catheter through a little bit easier. If you do get hung up on the ribs, if you just try and kind of twist that catheter as you're going through, it's going to spin your way through and then you'll kind of get through there and be all right. But keep that in mind when you're trying to do airway troubleshooting and suction. Just because you're not able to advance that suction catheter at first, make sure it's not just hung up on the Omniflex, okay? We're more worried about obstructions further on down through the tube and everything. So the Omniflex adapter, the accordion adapter, takes torque off your airway, should be used for all your tracheostomy patients who are requiring ventilation. We'll talk more about that inline suction catheter here in just a little bit. Okay, so we talked about the different Shileys, Bavona trachs. I showed you a regular Bavona TTS. I've showed you these other ones in class. Okay, so we have the extra length Bavonas with the Hyperflex. These come in a bunch of different lengths. Most of the more recent ones actually tell you, 110 millimeters, 120 millimeters, 90 millimeters, something like that. But these give us the ability of kind of having a patient with abnormal anatomy and we just need a longer trach. We can essentially use this kind of softer, more soft and forming trach and everything like that. If you need kind of a proximal distal length extension versus a distal and everything like that, it gives you a little bit more of a customability with that. Okay, so that's the fixed Hyperflex. Once again, they come in different lengths. It's important to know if you got an extra length trach versus a regular length and everything like that. Then we got the adjustable Hyperflex, okay? So you notice both these still are cuffed airways. They're both type to shaft variations. So it looks like it goes away. You got sterile water here for both of these, all right? So what's unique about the adjustable Hyperflex, it gives us the ability to not only have the, kind of forming and changing and stuff like that, but we can get a little degree of customization because we can actually pull this little piece off and we can advance this and lock it in place and everything, okay? So a lot of times you'll see these trachs get placed wrong in people or they don't confirm it with a bronchoscopy, and sometimes that thing can be sitting up against the wall of the trachea or something like that. So I have had problems, and we'll address that kind of as we get into there, some airway troubleshooting stuff and everything. But if this thing is not properly placed, you can end up being in the back wall of the trachea, or it could be curled back and around or something like that. So it should be hopefully adjusted through bronchoscopy where it's sitting in really the middle of that patient's trachea. Once we get a depth that kind of works, once again, it should be confirmed via bronchoscopy. So I'm going to advance this thing to 10. Okay, you need to pull and lock that flange in. And then just like with any regular airway, we're checking depth. So as a part of your routine assessment, you'd make sure and you'd say, okay, we're 10 at the flange here. And we're measuring right where that little buckle goes around it, okay? So it's important to remember that that thing needs to be locked and making sure we're confirming placement and everything, okay? So you can see that would give us an extra length. Once again, this thing could kind of vary how it needed to inside of the trachea, but you could have that extra length outside or you could have the extra length inside. So it gives us a different degree of customization when we're not really sure what that patient might need. And these come in a couple of different lengths too. Typically, like this one's 130 millimeters long. All right. So I don't have a foam cuff. I do in lab. You're probably not going to see them a whole lot. Just keep in mind that it's just a pilot balloon that's red, meaning stop. Don't inflate it with anything. After we inflate it, we either hook up with an adapter and it uses the pressure from the ventilator to inflate the cuff, or it's open to the atmosphere and it seals it. I haven't seen a foam cuff used in quite a while, I'll tell you that. The Jackson trachs, I didn't bring one with me. I'm doing this video from home, obviously. That's the silver-looking trach, good for just access to the tracheostomy or for your airway and everything like that. Not good for positive pressure because there's no cuff, there's no 15 millimeter adapter or anything like that. What we're seeing instead of Jacksons a lot more is just regular cuffless trachs, or you're going to see the Larry tube, what looks like a big funnel or a big outer or a big inner cannula with a big kind of rounded flange that sticks into that and just maintains that airway patency and stuff like that. So we're using them kind of in lieu of a trach button, and you probably learned about with Lindsay. Okay, so you still might see them, but a lot of times they're just for if you need access for suction and or patency, but they're not going to help us if something bad happens necessarily. Okay, suction catheters. We talked about the inline catheters here. Okay, gives you the benefit of being able to maintain ventilation while you're actually suctioning that patient. Makes sterile suction way easier and everything like that. Essentially, you don't lose PEEP when the patient's on the ventilator as we would if we had to pop them off and suction them and everything. So these things are a preferred method for ventilating patients that are, are for patients that are on the ventilator and everything and suction. Likewise, you could have a tracheostomy patient that needs a T-piece or something. This can be hooked up. You could take this little end off and you could have that hooked to corrugated tubing, and essentially you can use these as a T-piece and everything like that. I do still like to use this along with my little Omniflex here. Okay, so it gives you the ability for a T-piece. When we're going down and suction, I showed you I use my little push-pull. You want to pull that sheath back so it bunches up at the back end there. Okay, and it allows me to get down a little bit quicker versus you'll see people that push it and it all gets bunched up. And sometimes it gets to the point where you're not able to get down there in as quick of a manner. With, open suction, same process for the most part, just a different piece of equipment. You're using a regular suction catheter. You're still going to have a different thumb control port. With this one, I showed you this thing locks, so make sure if you twist it before you go down, you make sure it's not locked. Okay, likewise, I try and lock it before I leave. That way the patient doesn't end up getting suction when they're not wanting it. But that doesn't apply vacuum until you press and hold on that. Your suction tubing hooks up down here. All right, as you draw back, if you had a bunch of gunk on here, you got a little lavage port. So you can hook a 10 cc saline flush or a little pink squirt. Slowly advance saline through as we're pushing our finger on the thumb control port, and that kind of clears that thing up and out of there. And then making sure you put that cap back on, otherwise you get a leak from the ventilator. Okay, making sure you don't pull that thing back too far. You shouldn't see that big black line all the way right there. Okay, if you pull it back, it fills up like a balloon. Likewise, making sure you don't leave it down in that patient's airway can add on to the resistance. So biggest benefit is, once again, it doesn't disrupt ventilation. You don't lose PEEP. And it's easier to do, really, less chance for infection, hopefully. But if you're doing true sterile technique for open suction, it shouldn't be a problem either. You guys know how to pick proper size suction catheters. You should know some of the bad things that can happen with suction, not only mucosal trauma and everything like that, but you can have, acute stuff, so bradycardia, hypotension, increased ICP. All right, so making sure that you're only suctioning when they truly need it, and making sure that you're being gentle enough and using proper suction pressures, trying to limit that less than 150 millimeters of mercury. Let's see, what else do I have here? Okay, the rigid tonsillar or the Yankar. These come in a bunch of different variations. Some of them have a little thumb control button. That way it's not continuously suction. Some of them have a sheath that goes over it. This is for your thick, nasty stuff in the back of somebody's mouth, oral secretions, vomit, stuff like that. All right, you aren't limited to only 150 millimeters of mercury with these. If I got somebody that's vomiting, I'll put this to fully back, but essentially gives us the ability to kind of follow that curvature, get stuff in the back of the throat and everything, whether that's during intubation, prior to extubation, whether that's just somebody vomiting or somebody that's just clearing their secretions in the ICU. This is for the oral secretions that are a lot thicker and stuff like that. As I mentioned, this isn't for people using to suction out their own trach and stuff. That's just gross. Okay, you should be using a flexible catheter. So Yankar, this is for your thick kind of upper airway oral secretions and stuff like that. I'm going to show you this next device on a difficult airway video. All right, but the Bushi, one of my favorite respiratory words. It's usually got units of measurement on there. Mine has seen some abuse, so you can't really see your depths, but you usually would. Okay, you can see you got the end right here that kind of sticks out, and that allows us to have some purposes for using it for in lieu of intubation. So the Bushi, there's a couple of other different fancier versions. One called the Frova that allows you to hook up oxygen and stuff like that. This can be used as a difficult airway device, so we can actually do this to help essentially intubate when we're having trouble seeing the cords and getting down and through there. We can use this for exchanging out an ET tube. If we had somebody with a blown cuff or something like that, we could go ahead and you can use this. You could push this down and into the trachea. You wouldn't want to stick it out the end like that, and then have somebody slowly deflate the cuff, pull it up and out of there, and then you load another ET tube on. All right, and then slide that thing into place. You don't have to worry about trying to re-intubate and not getting it. It kind of lays the tracks for you to follow. Okay, you can also use this blind. All right, if that little tip, if you get that up and into the cords and into the trachea, you actually feel and hear that thing kind of hitting the C rings on the trachea and stuff. So when you can't see the cords, but you think you can get this up and through there, you can slide this in. You could have an ET tube loaded on this. Likewise, you could use it in a finger scalpel Bushi technique for somebody who needs a surgical airway. So you're doing a CRike, get it through, get that just started, and then slide a tracheostomy tube down and in. But we don't use this on routine trach changes or anything like that. It's only for emergent, like CRike with iotomy type surgical airway placement and stuff. So the Bushi can be used for difficult airways, can be used for airway exchanges. It can be used in a lot of different situations. I'll kind of show you some videos with that. Okay. Other stuff I'll show you on another video, pilot line repair kit. So if you got somebody who gets a nick in their pilot line or their pilot balloon or their valve goes bad, you can actually use these kits to make some changes and hopefully avoid having to exchange that patient's ET tube. It's a little nerve-wracking when you use this because you actually have to cut the existing pilot line and remove the pilot balloon. And then you got to carefully make sure you thread this down into the pilot line, and you hope that it fixes your problem. So we'll talk about this in another segment. But pilot line repair kit, once again, if you get a nick in your pilot line, whether it's teeth, shaving incident, or whatever, or if your pilot balloon goes bad, you can swap this out or try and salvage it and swap that out by using this little kit here. All right, so LMAs versus I-gels. So we have supraglottic airways, meaning these don't penetrate the larynx. They're like a mask of the larynx. They're a step up above manual ventilation. They don't provide airway protection, okay? Essentially, the LMA, laryngeal mask airway, it's like a mask on the end of a tube. You usually need at least a 30 cc syringe for these. And, there's different sizes, 3, 4, and 5. And it's all weight-based here. So it'll tell you what size, and this is actual body weight, okay? It's not an exact thing, but it gives you general guidelines. The larger the number, the bigger the tube, obviously. So essentially, this tip sits in the esophagus, and then this actually masks the airway itself. And hopefully you got, the epiglottis is kind of pulled forward and everything. This is if you can't get a patient intubated, or if you don't want to manually ventilate, or you're having trouble manually ventilating them. They're usually used in surgery sometimes. But once again, it does not provide airway protection. We can use this as a bridge to establish in an airway. We can use this to buy a little time when we can't manually ventilate. But these aren't things we routinely use in critical care medicine. All right. And really placing these things as beyond the scope of this video here today, but you need a big syringe. So they do make intubating LMAs where you can get that in, and then there's a piece you can actually try and direct an ET tube through there and do kind of blind intubation, but that doesn't always work, and not every place is going to have those. The I-gels are a little bit different. Same general premise. It's a much more soft kind of material. You don't need a syringe with these. Same deal, 3, 4s, and 5s, and it's true actual weight based, okay? So you can see Same deal, just no big balloon on the end, and it's supposed to make a good seal on there. These things, same deal, does not protect the airway. It's essentially something that allows you to ventilate your patient when you can't do so with manual ventilation. All right. So a lot of times somebody come in with the LMA, EMS is kind of using more eye gels and stuff like that. You come in with an eye gel, we end up having to just completely pull it out and intubate these patients and stuff. Okay. A lot of times you have somebody that they have this in, but it's leaking. You're not getting good chest rise. You can try and remanipulate it and stuff. But once again, our goal is to establish a true airway in a patient in the ICUs and emergency rooms and stuff and get rid of these. Okay. So you need a syringe with an LMA. You need no syringe with the eye gel. Neither provide true airway protection. It's just a step up above manual ventilation when you're having difficulty. It can buy you some time if you're having trouble manually ventilating them and trying to avoid having to do emergent trach or something like that. So CRike Kit, I don't have one with me. I can show you some videos. We can play around with this in the lab. Once again, it's for emergent cases where a patient is going to die, okay? So you can't oxygenate, can't ventilate. You balloon all your chances for establishing that airway, and they're going to die. We need to do an emergency surgical airway on them. Cricothyrotomy is a preferred method because it's quick. It's a little higher, obviously, than a regular trach that would be sitting down, you know, second or third cartilage ring. Being able to find that, and essentially we use a syringe with saline, try and poke through, draw back until we get air bubbles, take that syringe off. We know when we got a needle in there and start advancing like guide wires through, pull that out, make a couple of little cross cuts, and then try and slide a trach in. You don't need a CRike Kit. Once again, you can do the finger scalpel Bushi. So same technique with a needle, find it in there, open them up with a scalpel, stick the Bushi down and in, and try and slide an ET, or you can actually put an ET tube in, or you can do a tracheostomy tube and pull that thing up and out of there, and then we can worry about establishing a more formal airway after they're not going to hopefully die on us. Okay. Next thing, cufflators. So Posey cufflator. I showed you some of the other little digital throwaway things for checking cuff pressure. Our goal is a cuff pressure, you know, really 25 to 30 centimeters of water. Above 30, we're worried about mucosal ischemia. Below 20, I mean, we'll accept 20 to 30, usually 25 to 30. Cuff pressure is below 20, we're worried about microaspiration. So secretions from the upper airway draining down into the lower airways and causing problems. The Posey allows you to deflate by hitting the red button, right? Allows you to inflate by squeezing the bulb, and then your pilot balloon actually just hooks up right here on the side. So you can see me inflate that. I can check the cuff pressure and everything. I can relieve that down. Don't be fooled by mine, okay? It shows you that an ideal cuff pressure is like 12 to 30. We really want to see that 20 to 30. Most of the time, 25 to 30 is kind of what I stray from. We still need to make sure we got that airway sealed, okay? So a lot of times you need to know how to do minimal occlusion volume. This simply just allows us to check our work. If you're at a cuff pressure of 30 and you still got a leak, we need to inflate that using the minimal occlusion volume, all right? Keep that airway sealed. But the problem could be that airway, the patient's tube was too small, and that puts them a little bit more risk for some mucosal ischemia and problems post-extubation. So Posey cufflator, knowing normal cuff pressures and stuff like that and how to utilize these. Cuff pressures are typically checked at least once a shift. I didn't bring a King tube with me, okay, but a King tube is essentially an esophageal obturator airway, meaning we intentionally stick it down into the esophagus, all right, inflate a big balloon to seal, and then essentially another balloon seals down in the esophagus, so the only way air can go is hopefully through the vocal cords and into the trachea. It's an EMS tool. We don't use them at the hospital, okay? But what you'll see is sometimes people come in with a King tube. You need a big syringe. I usually like a 60 cc syringe to drop this balloon, and we have to just get everything ready and get these patients intubated. So it doesn't actually do much. It's a step up above manual ventilation, but it doesn't protect that patient's airway necessarily. They could still vomit, although their esophagus should be sealed with a balloon. It's an emergency medicine thing. And most of the EMS guys I've seen are using more LMAs or eye gels and stuff like that rather than these esophageal airways or these King tubes. So I'll show you that in class. Okay, I believe that concludes everything we need to talk about. Oh, one more thing here. The Lucan's tracker specimen trap. I showed you if you're going to go ahead and get a sputum sample, you would go ahead, make sure you got a clean suction catheter or a new suction catheter. You don't want something they've been on for a long period of time, okay? That hooks on right like that. Your suction tubing hook on, and you could go down your airway. As you suction it, it's going to drop down and in here. If you get stuff hung up in your tubing, you can use this little lavage port, draw some saline through, suck that stuff down and in. take that out. You can either do something like this and then affix the proper lab requisition label on here, or most of them come with a white cap. Take that off, put the white cap on, put it in a biohazard bag, and send it down to the lab. Okay, biohazard bag is essential. The lab people will not like you if you send just a random tube of some bodily fluid or substance in the tube system. You will definitely go on their list. So make sure anytime you're sending samples and stuff, you put in a biohazard bag. It's a lot of equipment there. Once again, I'll show you some stuff and some different kind of airway troubleshooting videos and stuff. But that's essentially the type of stuff I need you to know for your practicum, and the things you should all feel comfortable with and proficient with in regards to, approaching airway management and your critical care rotation. So I hope that helps. As always, you got any questions, let me know. Bye.